Thanks for joining us for the session that's not about multiple micronutrient supplementation today. So, I appreciate that you're here. There are a lot of competing sessions running at the same time, but data for decision making is a topic that's of interest and of priority to my organization, Nutrition International, and really fortunate to have some partners and really distinguished speakers with me today also to help me cover this topic. We also have, I think, coffee and tea here, so feel free to grab some, and we're going to start. Also, thanks to the participants online. Maybe just starting also to just talk about the arrangements for the session. We'll have a series of speakers. We will not take questions in between, but at the end of that, we will have a good amount of time for question and answers. Those of you who are online, you can submit your questions. We will also take questions from the room. So looking forward to getting your opinions and questions at the end of the session as well. So with that, if I can have the first presentation up. Okay, so it's good here, but it's not showing. That's what you mean. This is the one? Yeah, but why is it not showing? So it's on the screen here, but it's not showing up. Okay, perfect. My name is Vandana Rabi, and I'm Vice President and Chief Technical Advisor at Nutrition International. And I'll be starting the session just to set the stage for why we chose this topic for today's conversation about data for decision making in public health nutrition. Briefly, I wanted to show you a framework that we have for Nutrition International about how we really work on taking evidence to action. And when we talk about evidence, this could be learnings that come from efficacy studies, from systematic reviews, really where there is a body of knowledge about interventions in nutrition and in public health nutrition that can make a difference. And from there, after we identify what works from some of these basic studies, we actually then have to take them to the field and to the real life conditions. So we actually have to have intervention designs and implementation research where we look at how you can actually implement in the field, take those interventions to the context where multiple factors could be in play to affect your delivery of services. And then identify the gaps, identify some formative research questions, experiences of seekers and recipients of services as well, and also looking at the programmatic aspects of implementation. For example, partners who are working together, delivery channels for interventions, and eventually we work on what we call a program pathway. So this is the pathway through which an intervention is delivered and through which an intervention ideally has an effect on the recipients. Then we also work on proving that implementation is successful. So, you build these programs, you implement them, but you also have to really check and see whether they are having the impact that we suppose they would have. So we do process evaluations, we do output to purpose reviews, we have this whole cycle of using data for decisions across program quality topics. We have what we call them NIMS. These are surveys that look at the coverage of different indicators. We have quarterly reviews, look at analytics of how the coverage is going on, what's happening to the stocks if there is a supply issue. We try to identify those. In general, really across the program cycle, there are always questions related to what's the best way to approach a certain aspect of a program and improve the quality. We also work providing ongoing technical assistance to the government, so there is understanding and support for the program, and helps with the sustainability and uptake by the local decision makers, and ongoing technical supervision and translation of global evidence as well. So if there is new evidence about better ways of program delivery, we try to incorporate them in our ongoing work as well. And then eventually, as we are moving forward in public health nutrition, we don't focus on a single intervention. As you know, we have a mix of interventions in different contexts, and we always work on what we call an optimal mix of interventions, where you look at the needs, the diet and practice deficiencies, and you work on interventions that would give us the best mix of options that would give you the best nutrition outcomes. So because we do that, in addition to making sure that every single intervention is implemented well, we also have to look at across the board portfolios of interventions and portfolios of programs. And again, looking at data and looking at how those portfolios are performing. And we look at, for example, our portfolio on child survival. How are we having an impact on mortality in children? We look at our portfolio on anemia. How are we working on reducing anemia rates in our key target populations, women of reproductive age, young children? So those are the types of portfolios that we look at. And again, data can help us understand better how we are performing and improve the quality. And then eventually, it's all about going to scale. And this information that's gathered and implemented through the process, and to the program process, has to also be then helping us to go to scale. What are the elements for scaling up, moving from, a few districts where you start the programs, usually with a smaller scale. Ideally, we want to have national scale when it makes sense. And then this scale up could also be leading to regional and country and, eventually even global level learnings and program guidance and recommendations. So this is really a complicated, intricate, and very connected framework for linking evidence to action. And really data is something that is needed throughout. And quality data is something that's really the best way you can actually have all of the decisions in all of these stages to become relevant and to be good decisions that help improve the quality of programs. So this topic of data for decision-making really is something that at Nutrition International we have identified as a priority. And also we want to make sure that we use global, national, and country-level data to help the stakeholders through their strategic decision-making, to be able to do analytics and data analysis to improve nutrition advocacy, help government decision-making, improve investments in nutrition, and eventually we want to, of course, improve and optimize the benefit to those most in need. So in doing so, we have this element of data itself, and increasingly we are moving to big data, to multiple sources of data. Then there is this element of analytics, because of course data is good, but really unless you give it some meaning to analysis, you can't actually use it for decisions. And then certain tools that actually help you make that data usable or interpret that data better and link it to decisions better. So we invest in analyzing data, in translating it, and also moving it towards action. And overall, this is what can give you the data for decision-making process overall. In opening the session, I wanted to really kind of talk about some of the issues that I think the public sector in general is grappling with in this whole data for decision-making framework. One issue for nutrition and public health nutrition has been which data for what types of decisions. And I still think we are not very clear about this, and it would be good to have these discussions to get more clarity on those. And I mentioned in one of the previous slides, data could be needed for advocacy, it could be needed for increasing investments, it could be needed for decision-making about components of the program. And each of those decisions might need a different kind of data and might need a different level of rigor and detail in data. I think as scientists and maybe more kind of technical-oriented people, sometimes we want to have the best data, definitely have multiple micronutrient surveys at the national level that have all the biomarkers included. But that's of course data and important information for certain types of decisions. But it's not necessarily what you need for every kind of decision at every level. Sometimes you can also make decisions based on modeling, based on probably different kinds of sampling or some creative analyses that still enable good decision-making at different levels. So there is just this lack of clarity, and I think we can get better at really helping provide guidance on what kind of data is needed for what type of decisions, especially at the country level. There's always the issue of cost then, especially again for those data-based decisions that need data on costly biomarkers, let's say, or survey-based information. Linked to that, there is the issue of capacity, and capacity is not just related to data collection, it's also about data analysis. A lot of us who've worked at the country level know that even they have these beautiful micronutrient surveys, but then they end up as a report on somebody's desk eventually, and again, that's not a good use of data necessarily, and a lot of times it's because there is not enough capacity to make use of that data and link that data to good decisions. So then we have the next topic, which is also the analysis and utilization, which is another topic that especially I think in the public sector we are grappling with. And we need capacity and investments in making sure that data is linked to decisions. I wanted to also bring another topic that I think is very important, and I'm hoping that also this panel will help us think through, coming from the backgrounds that they have, and you'll get to know them more after I finish, is the whole issue of ethical considerations related to data in the public health decision-making arena. Again, this is also something that even in our personal lives we are dealing with all of our data now being available in the public spaces on many different levels. So issues of data governance, stewardship, ownership. Just in the previous session in this room, they were talking about adolescent nutrition programs, and there was this great presentation about an app that's being used for uptake of information from adolescents about their use of supplements. And the screen capture that they were showing had the name and age and the school name of all the adolescents on it. So, immediately there was a question about data and privacy and protection in my mind that, I kind of afterwards and asked. So even in your day-to-day and in our best intended interventions, there are some of these issues that I think we have to learn to be dealing better with. There is stewardship, ownership of the public data as well that's important. Increasingly, the global research community is addressing the issue of demonstrating and establishing benefit to the community from whom we are collecting the data. And again, research in the past, especially research in the developing world, has been a bit dissociated from benefits to the community. So really data collection for the sake of just knowledge or data is not justified. We have to be able to at least justify, if you are doing a household survey, really eventually, is this something that would have some benefit or would enable some beneficial decision making for those households? And I think it's something that we have to, again, consider as we are doing ethical reviews for research, as we are making decisions about conducting surveys or supporting surveys through our organizations. And then eventually I wanted to bring the issue of neutrality and conflict of interest. I think in the field of public health nutrition, this is a broader issue. It's not even just data. I think it's about influence. It's about really neutrality in making the best decisions that are good for public health, good for nutrition, and in that, making sure that there are no undue influences in that process. We are talking now about, in this presentation, I'm focusing on public sector. So here, of course, we have to be careful about influences from the private sector where there may be conflict of interest. We have to make sure that, again, that data is also being used for public benefit, ideally, as much as possible, and really address these issues openly and transparently and early on. And I think this is something that, especially the nutrition community, needs to be paying more serious attention to, and I'm hoping to be able to contribute to that, starting maybe actually from the data conversation, learning from what's being done in other fields in public health, in health systems, information, and bring that into the field of nutrition as well. And eventually, I think we need honest brokers for these processes to support the data ecosystem for better decision-making across the board. And I just wanted to close. This is something that has gotten myself thinking for a while, and I just wanted to pose this. It's about keeping up with advances in the field, and that is also one of the topics. You will hear some of the presentations in this panel are quite innovative and forward-thinking. I think for me, what's close to my heart is really thinking about how we can channel these innovations in generation and use of data to those who need to benefit from it, those especially for benefiting the poor. And there's this quote in a blog from Bill Gates that I read over the summer as ChatGPT had been publicized and the age of AI has begun. And what he himself is saying here is, market forces won't naturally produce AI products and services that help the poorest. So the opposite is more likely, and with reliable funding and the right policies, governments and philanthropy can ensure that AI is used to reduce inequality. So I think I just want to close with that. We are talking about innovation in data and really bringing these frontier advances to serve the poor. But we also should acknowledge that they don't just naturally happen. These are not the populations that are the target or the audience for some of these advances. And I think it's probably on us to think about how we can make investments to make these innovations available and accessible and beneficial to the poor. So I'm also posing that to the panel and to all of us, and I'm hoping we can come back to that conversation afterwards as well. Thank you very much. So I'm going to hand it over to our next speaker with that, who is Navida Nouri, and she's going to give us a little bit more about her background and then talk about her modeling work. Thank you.
Thank you, Mandana. Hello, everyone. Thanks for being here online or in person. And thanks, Mandana, for organizing this session. It's a pleasure to be here and present my work. I'm a senior research scientist at Institute for Disease Modeling at Bill and Melinda Gates Foundation. My background is mainly data analysis and modeling, not nutritionist by any means. But today, my talk will focus on using different analytical methods and modeling for the purpose of targeting nutrition interventions to the vulnerable population. So undernutrition remains an underlying cause of death among about 50% of children under the age of 5 every year. And there is also this bidirectional relationship and interaction that exists between undernutrition and infection that can be devastating to child health. As well as that, many of children who are at high risk of malnutrition are the same who are missing out on critical immunization services. And despite decades of progress in increasing access to immunization services in lower-income countries, at least about over 12 million children every year go without any basic routine vaccines. Many of these missed communities, they face multiple levels of vulnerabilities, from lack of services to socioeconomic inequities and other gender-related barriers. To be able to better integrate nutrition interventions, immunizations, and other primary healthcare services for the purpose of increasing reach and sustainability, it is important to identify high-risk groups that have poor access or usage of essential health services, and also assess whether there is an overlap between the risk factors that are leading to undernutrition, leading to low immunization, as well as the underutilization of other health services. Understanding the different drivers of vulnerability at the different levels of community, health, household, or individual level, and from different aspects of social, cultural, and environmental drivers of vulnerability can enable the global health community to address the root causes of behaviors that would lead to poor health outcomes. So with this background, to be able to identify the vulnerable populations and for the purpose of targeted intervention, especially when we are thinking about nutrition interventions and immunizations, we use the Pathway Framework, which is a body of work and a design project at the Gates Foundation that focuses on identifying and addressing vulnerable women and their children under the age of 5 by exploring a range of social, economical, cultural, and environmental variables that could create health risk and also could influence the health-seeking behaviors of vulnerable families in the vulnerable settings. So as shown in this graph here, what it does is that it clusters women according to the likelihood they will experience a higher level of vulnerability to a range of maternal, newborn, and child health outcomes. This pathway frameworks and this methodology considers different domains of vulnerability, as shown in this slide here, from women's lifetime experience to economic condition to social support, as well as to climate and environmental data. And it assumes that all these vulnerabilities could predict health behaviors and health outcomes. So what is the analysis process for this pathway framework or segmentation is that it goes over a list of vulnerability-related factors that you can obtain from survey data and tries to cluster them based on their relevance to a specific maternal, newborn, and child health outcome indicators and to define a set of latent factors from those vulnerability factors. The next step is that try to develop a regression model or relationships to identify the association between those clustered vulnerability factors and the MNCH outcomes. And then last step is segmentation, which uses unsupervised machine learning approaches such as k-means clusterings and other methods to divide individuals into the groups based on their similarity across multiple variables. So what it does is that each household is assigned to a segment, and then we can use multivariate modeling techniques to, for instance, predict different outcomes such as stunting and wasting as a function of segments as well as other variables. For this purpose and for this study, to be able again to identify the vulnerable population and targeted intervention, we use this pathway framework as segmentation methodology, applied it to the DHS data in northern Nigeria, and we went through this analysis process that I showed you in previous slide, and we defined 7 different segments. They are clustered by their vulnerabilities as well as the context. Some of those variables that came on top of the list in terms of being important for these data sets and this region was, for instance, being in rural versus urban area, being male-headed versus female-headed households, and also having different level of vulnerabilities that leads to poor health outcomes. As an example here, if you look at the RF, one of the segments that's called RF1, R refers to rural, F refers to female-headed household, and 1 defines the level of vulnerability, with 1 being the least vulnerable household, and it goes up to 4 here. For instance, RF4 shows the most vulnerable household. So while there are segments that have similar health outcomes here, their vulnerability profiles differ from each other. So next step, what we did, we wanted to see what is the segment membership in northern Nigeria DHS. So the plot on the top right-hand side shows the number of children that are inside each of these segments. Some of them have low number of samples, some of them have higher. And then we wanted also to see what is the percent of children inside each segment who are wasted or stunted, which is these 2 plots, colored plots as shown here. We wanted to see if segments are predictive of these child growth failure indicators. And that's what we are showing in this plot. So we predicted stunting as a function of segment membership using this data set in northern Nigeria. So y-axis shows those different segments that I mentioned earlier, and the x-axis shows probability of stunting. So we see a significant difference in stunting probability between segments, which shows this gradient by level of vulnerability. So the way these segments are ordered is from least vulnerable segments to most vulnerable segments on the y-axis, and we see that the probability of stunting among those segments who are the most vulnerable, such as UM4, RF4, and RF4, are much higher than stunting probability among the least vulnerable segments. For wasting, the results are not as straightforward, and the confidence interval actually here is much wider, which because of the sample size and number of cases that exist within each of these segments. But what we can see here is that the wasting probability in urban segments is slightly higher, although they all overlap with each other, than the rural segments, especially when we look at the segments that have similar level of vulnerabilities. For instance, if you look at these 3 segments here, the probability of wasting among the segment that is urban in urban households is higher than those that are in rural households here. It's definitely something that we need to explore more to identify what are the other risk factors that drive this pattern. After looking at the relationship between these segments and if vulnerability that are derived in these segments predict stunting and wasting, To be able to increase feasibility of targeting and maximizing impact, nutrition interventions should be integrated with different health services. So to explore the potential overlap that we see between child growth failure and other indicators of poor child health outcomes, we defined a range of variables, and we came up with an index of health service utilizations. These are the variables that are reported in DHS, for instance, whether a household has a zero-dose children or not, whether they've had home versus facility delivery, had any ANC visits, PNC checkups, ever used modern contraception, whether they visited the health facility over the past 12 months, and whether they received vitamin A dose in the last 6 months. And then we gave them a score of from 0 to 7, with a score of 0 being that none of these 7 services or cases have been used by this specific household. And a score 7 means that has highest level of health service utilization. It means all of these services were used by the households. So then we wanted to plot them versus segments again and see what is the pattern that we see. So here we are looking at the distribution of these scores within each segment. And when the darker color here represents the lowest level of health service utilization, and the brighter colors is the highest level of health service utilizations. And we ordered the segments on the x-axis from the most vulnerable to least vulnerable segments. What we see here is that segments are strong predictors of health service utilization score as well. And the same households that had high prevalence of stunting, they are those who actually have low health service utilization, which emphasizes the importance of service delivery and integrations of different interventions, especially when it comes to nutrition interventions with other health services. So these 3 segments that were most vulnerable population or households, 42% of households in the RM4 segment, 33% of households in RF4 segment, and 26% of households in UM4 segment, they have not used any of those 7 listed health services that I mentioned in the previous slide. So given this background and our findings and identifying this overlap between child stunting and wasting and underutilization of other health services, and also given that, as I mentioned earlier, many of the children who are at high risk of malnutrition are those that actually missing out on immunization services, there have been some recent efforts to join forces to combine nutritional supplementation with immunization to be able to save more lives. There has been also evidence for food incentivizing vaccination, from providing a bag of lentils for each immunization visit in India, where it shows that it has large positive impacts on immunization uptake in this low resource setting, to a 1,000 days program in Alima that was conducted by Alima in Niger, in rural Niger, by their Nigerian partner, where they provided an integrated package of curative and preventative interventions, and they added SQLNS, a small quantity lipid-based nutrition supplementation, to their package. And by the end of the study, they saw that there was about 25% increase in the first dose of measles vaccine uptake in the region, which emphasizes the usefulness of food supplementation to incentivize vaccination uptake. So we attempted to quantify these potential health benefits of this synergy by developing a population-level compartmental model of measles transmission for children aged 6 to 23 months of age, and we stratified them by their nutrition status, wasted versus not wasted, and we informed our model assumptions by the intervention that was carried out by Alima, and I mentioned in previous slide. This work has been published, so if you want to know about more details and assumptions of the model, you can check out the publication, and also I'll be happy to talk to you about it after the session. But a more simplified version of this model here, we simulated a range of scenarios to assess the potential reduction in measles burden, which are associated with different nutrition interventions. So one assumption that we had was that nutrition interventions were assumed to increase engagement with the health sector and therefore lead to an increase in vaccination rate. With that being said, for this age group, we assume that some proportion of children who are wasted receive therapeutic feeding, We accounted for relapse in their model, and after receiving treatment, they moved to non-wasted children, and as a result of interaction with the health sector, we assumed there is an increase in vaccination coverage. The second scenario, we assume that a proportion of children receive SQLNS, and as a result of it, there are some changes in model parameters based on the meta-analysis and previous study that was found as a result of effects of SQLNS. And we also assume that this leads to an increase in vaccination coverage. We call the first scenario treatment, the second prevention, and third one, we combine these two, treatment and prevention, together. And we are looking at the measles burden here. So what I'm showing on the y-axis is number of infected cases among wasted children per year. And if we assume that in two scenarios, one that is only treatment and second treatment plus prevention, if we assume that the treatment coverage in these two scenarios are same, let's say 25%, which is the gray bar on the first panel, and the purple bars on the second panel, we see that the number of measles infected cases among wasted children per year declined by 3 times, from about 16,000 to 4,500. And we found similar results for the mortality due to measles as well. So this emphasizes that the effects of provision of mass nutrition supplementation are reducing the number of wasted children and therefore wasted infected children by measles is much larger than the treatment effect. So in conclusion, I think our analysis showed that pathways can reflect on compounding vulnerabilities that give rise to persistent inequalities in overall burden of disease. We could identify malnourished children and their overlap between undernutrition and overall health-seeking behavior and health service utilization, such as under-immunization, which emphasizes the importance of service delivery integration. And then our dynamic model of measles and undernutrition work highlights the synergic benefits that may be achieved by leveraging mass supplementation as a touch base with the health point and the health system to be able to increase rate of vaccination as well as overall child survival beyond what we expect to get from each of these interventions alone. Thank you so much.
Thank you very much, Navide. Great presentation, and also very relevant to the topic of the conference, which is resilience, and really a new way to even think about defining vulnerability. Our next speaker is Abe Tarpani from Atlas AI, who will be talking about geospatial machine learning applications for better targeting of nutrition interventions. Abe.
Thank you. Great to be with everyone this afternoon. I'm Abe Tarpani from Atlas AI. We're a public benefit corporation based between the US and East Africa. I'm happy to join the panel. Mandana, thank you for including us today, both to talk about the broader applications that we're seeing in the development sector for harnessing new types of data inputs, new types of AI techniques, as well as the applications that are emerging from those across many different sectors, including in public health and nutrition. So a bit of history on Atlas AI. We emerged out of Stanford University in 2018. The work behind the company emerged over about 10 or 15 years of academic research as a collaboration between the School of Earth System Science and the Department of Computer Science at Stanford. So effectively, the team of researchers working on the underlying thesis behind the company were testing this question of whether satellite imagery and other sensors that were capturing data about change on the planet could be reliably harnessed to predict development indicators at high resolution. So the early papers that they published first demonstrated that in a location where you have high-quality household survey data, so this is survey data from DHS or LSMS or other international organizations that are capturing reliable information within certain countries, you could develop models that interpreted the pixels within a range of different satellite images to predict back certain outcomes within that survey data. So for example, if you had survey data from Kenya in 2010, you could predict back the asset wealth of a household on a community-by-community basis using satellite imagery and AI techniques that this team developed. And over time, they demonstrated that if you had that survey data in 2010, you could also predict values in 2011 or 2012, even if you don't have survey data during those periods. And then they demonstrated that there were AI techniques that would allow you to predict similar values in Uganda, even if that survey data is not available in that geography. So over time, the academic literature expanded to demonstrate how scalable and potentially powerful these techniques could be. They then turned their attention to the field of agriculture and showed how similar methods could understand how land use was evolving for agricultural purposes, and all the way to using satellite imagery to predict the yield of a smallholder field anywhere in the context of sub-Saharan Africa in this particular work. So thanks to support from the Rockefeller Foundation, Atlas AI emerged from that research, as I mentioned, as a public benefit corporation aiming to scale and make this data available to the development sector. So our team exists to continue to advance that science, but really importantly, to package it in infrastructure that makes it reliably produced year over year and in a format that is useful for development organizations to be able to take and apply in the context of their work across a range of different sectors. So an example of what emerges from this on the screen on the left-hand side of the slide is imagery in the foreground of an optical satellite image of the country of Kenya. In the background is an image taken at nighttime that measures the luminosity, the emitted light from local communities. On the right-hand side of the screen is what emerges. In this case, this is a data set that on a 1 kilometer by 1 kilometer basis estimates the spending capacity of a local household within the frame of that gridded cell. So we now have the opportunity to complement existing census and survey efforts with a data set that is updated every single year with freshness as of the last 12 months and is very predictive of the underlying survey data that's considered gold standard. Over time, we realized that asset wealth or spending power or agricultural use was not by itself enough, and so the team has worked to expand the use of these techniques to measure as much about community development as possible around the world. So pairing with those early indicators, we now produce data that tracks the expanse of electrification and energy access, the extent of road networks, the quality of roads, and the suitability of roads to transport agricultural produce to markets, the physical expansion of communities and how the footprint is expanding and what that means for economic growth and opportunity, and even a map of assets like schools or health clinics and other key points of interest within the region that are fundamental to understanding how networks need to emerge to connect communities to key services. This information is now available in 75 countries, the entirety of Africa, all of South Asia, and we're now in 2023 expanding it to the majority of the Asia-Pacific region as well. So the data by itself is only so good as its ability to help answer questions, and we've always, from early on, recognized that most organizations, given this type of extremely rich data, are going to have limited internal capacity to be able to harness that to directly inform program design or monitoring activities or other operational activities that can benefit from more up-to-date, granular local insight. What we find is that our partners who are using this information are typically trying to answer one of 4 questions. At the most basic level, a question about querying the information to find locations of interest. So how do we, across all of the different subsets of information being captured, find locations that meet our criteria in terms of levels of poverty, recency of energy access, proximity to key markets, or the like. The second indicator, which I'll talk more about throughout the rest of this presentation, focuses on modeling how this data can act as a predictor of downstream indicators of risk and vulnerability or of opportunity to expand investment. We're now starting to see the applications of this technology for forecasting, anticipating over the next 1 to 5 years how communities are likely to develop based on all of the historical information we have about their trajectory as well as recent insight into change. And then finally, we have a number of partners that are using this information to evaluate the impact of programs based on observed changes in the underlying data sets that Atlas AI has produced. And we just published a really exciting paper at the end of last year that demonstrates that using Atlas AI's wealth data, an organization can attribute impact to changes in household wealth from distributed infrastructure investments. In that context, it was a rural electrification program in Uganda. So to translate this into 3 specific applications, we have produced this information in support of humanitarian response. So the data within that section is a map of community-level structures across Turkey after the terrible earthquake that hit the country earlier this year. We made this data available on an open humanitarian license for both Turkey and Syria to aid in first response and development priorities in the aftermath. The second is in a more operational sense in terms of guiding program implementation and design. Where do you target limited resources to have the greatest impact based on a theory of change that can be inputted into the system? And then finally, measuring the impact and progress of infrastructure impact. So in this case, this was a national road program where there was a desire both to ensure that there was progress in expanding investments in roads, but also understanding the economic downstream impacts that those roads would result in at high temporal resolution. So as an example outside of the nutrition space, and then I'll talk for a few minutes about how we're applying this in the nutrition space, we've worked for several years with an organization in Africa named MyAgro. MyAgro is a nonprofit organization that provides training, seed inputs, and other types of resources and guidance to smallholder farmers across, I believe, 8 countries now across the continent. MyAgro was facing a question about where in the countries where they're operating, in this early context it was Senegal and Mali, where are the next set of villages where they should expand their programs to based on everything they've learned to date about the success and challenges of network expansion and all of the recent information on the entirety of the footprint of human settlements in those countries. To approach this work, we mapped all of the candidate villages that might be suitable for the expansion of MyAgro's programming and applied a multi-criteria analysis combining a range of different factors, including land use, climate, livelihoods data, density information, access data, to result in a unique predictor for MyAgro of village suitability for their program expansion purposes. The benefit of which was not just the upfront strategy input, but the fact that this model was connected into their operational systems and was continuing to learn and adapt and improve over time based on new input and outcome data that they were able to collect. They now are using the system for informing strategy across all 8 of their countries. And to talk for a minute about what that process looked like, a lot of it starts with methodology development and leaning on both historical evaluation results to Mandana's introductory comments, but also to literature review and relying on academic studies that have helped to inform what suitability and impact mean in the context of determinants of those outcomes. So we worked extensively with MyAgro to put together a theory of impact at the village level that resulted in relying on a range of different data inputs. Atlas AI's unique proprietary data, third-party data sets that we obtained from statistical agencies within those countries, as well as program data that MyAgro uniquely had access to from their historical program implementation. Then using a range of analytical techniques, we built the multi-criteria analysis framework to apply on a village-by-village basis. So for every human settlement across these countries, we had a unique score that recommended the nature of opportunity and vulnerability for those communities that resulted in a prioritization framework. And then finally, program evaluation. This system was able to enable them to monitor continuously the results and impacts coming from expanded program reach. So historically, as opposed to where they would do a midterm evaluation, a 5-year evaluation of results, now they were able to have access to almost real-time data that was coming through tracking the impact of their programs. I've mentioned a few times a map of human settlements. I wanted to share an example of what that looks like. This is a global map that Atlas AI has produced using satellite imagery that tracks the footprint of built-up structures across the globe. So this is an image where every pixel in the image represents 10 meters. So we can pick up almost every structure and every building on the planet. And it can be updated quarterly so that we're tracking change and expansion and destruction of settlements in a way that often indicates where programs need to adapt in order to respond to emerging conditions. We also, and this is a bit of a tricky image to see within, but if you can follow the yellow outline here, this is the map of the individual village itself. On top of that, we have attributed every single one of these communities with insights into population, market access, asset wealth, and other indicators. And the result is an operational GIS system that MyAgro can use on an ongoing basis to track progress, to set priorities, and again, importantly, to evaluate progress. So now finally turning to the context of the nutrition space, and we've had a really fruitful collaboration with Nutrition International over the past year to think about how these techniques apply in the context of the nutrition space. And I'll introduce at a relatively high level the focus of that work, which was on taking similar techniques that I introduced for MyAgro in terms of how do you develop a theory of vulnerability or risk in this context that stems from a range of different underlying data inputs and risk factors that Atlas AI is measuring through our platform. So the goal was relying again on literature to develop an ontology with, in this case, it was about 20 different input data sets that combined together in order to create a proxy for vulnerability at the village level across a number of countries and theoretically scalable to every country in Nutrition International's footprint. So the result is, again, a geospatial platform that has its unit of analysis, the human settlement. So this is showing an example from Malawi, where we've mapped every place that people live in Malawi, and every one of those settlements has a unique set of scores associated with the access to services, the vulnerability of the local community. And it allows us to then start tuning models that ask questions such as, in which villages do we see the highest number of children under the age of 5? Or where do we expect there to be the highest likelihood that there is presence of zero-dose children, which can then guide downstream program design priorities. Thank you very much.
Thank you very much, Abe. And it's really impressive to think about how we can really apply these, methods and models to nutrition. And as you heard, we are really just at the beginning of these explorations. Now we are going to move and shift gears a little bit and talk about a specific example of use of big data and analytics related to big data in food fortification. So I'm honored to introduce to you Dr. Florian Schorgert, who is going to be talking about big data for food fortification, decision-making, and sustainability.
Ladies and gentlemen, I would like to present you the data and the results of a review which we have written in cooperation with authors I'm acknowledging here, Fiona Walsh, Anna Sancho, Cory Lothringer, and Christoph Kratz. But I also will show you results which we are currently producing in Pakistan, where we are using a data-driven approach to monitor the fortification level of vitamin A in the edible oil. And in this context, I have to declare a conflict of interest. I'm not talking in my affiliation with the University of Potsdam, where I'm head of the Department of Nutrition, but I'm also a CSO and shareholder of the company BioAnalyt, which is producing eye-check and rapid tests to analyze vitamin A in edible oil, and these data are serving to monitor the efficacy of food fortification in different regions of the world. We have heard in the talk before, we have heard these application of big data, how they can be used, what they are creating. But we have to consider that things get only done if the data we gather can inform and inspire those in a position to make a difference. That means simply to create big data for what purpose does not help anything. We have to show on our way on using these big data how they can be used, how they can make a difference. And I think there are a lot of different aspects where we can show this to the specific stakeholders in the value chain of the nutritional aspects. We have heard about big data. You can see the different definition of big data. These are mass data produced in huge quantities, and we have seen the satellite data, but everything you carry around with you, any refrigerator, any farm equipment, everything produces millions and millions of data. From our perspective of analytics, 10 years ago, our devices and analytical stuff was producing one data point. Nowadays, each measurement we are doing producing millions of data points, of which we are using only a little fraction to extract some results out of it. What does it mean that only a very fraction is used? I will explain a little bit later. So we have, if you look at the pyramid, we have the science-driven approach to the big data, information and knowledge. And in these questions which are asked and refining the big data, we are coming to basically the question, how can this wisdom we are extracting from the big data can be used to make decision-based approaches and approaches which are decision-based. There are many trends which are supporting not only all the devices which are creating big data, telecommunication in low and income countries and middle income countries are increasing this. There's a lot of mechanisms that are used to bring this data basically together and analyze them. However, what we are discussing theoretically as a very easily used system, it causes a lot, it has a lot of challenges disguised into this. I would like to address how big data are used along the food value chain. And to understand the interpretation of the data later on, I will show you how we have structured the food value chain from inputs, which is seeds, fertilizer, and pesticides, going into the production side of farming production, then processing and packaging, where you basically have the food fortification issue mostly allocated and regulation, the quality assurance and the quality control going to distribution, retail and marketing, and last but not least, and we have heard a lot of these discussions and we will have more about public health monitoring. How are these data then all brought together? And you can imagine that at these different steps, there are huge, and you would assume there are huge of big data created, and I'll show you that this is not the case for all of this. It's very heterogeneous what is happening at the moment. Well, what are the drivers basically? What are the opportunities we nowadays have? It's basically private-public interventions and initiatives, basically low middle income countries. We have heard this discussion about measurement matters, what Bill Gates has shown in a video. You have to have the data to make a clear decision, but who is paying for this basically? But the private-public interventions are basically supporting these digital innovation. We have information communication technology, which is increasing availability of smartphones, and all this are contributing substantially to making a progress. I think one big driver is what comes from the food industry, not specifically from food fortification, is food traceability. Nowadays, each of us would love to know where the grain you are eating is coming from, what has happened to the grain, what is in the grain, is it contaminated or not, how has it been tested. All these data are available already in specific aspects and then can be integrated into this. And the big question is data sharing. How ready is our society? How ready are different stakeholders to share the data they are generating? There are examples of, in the COVID venicity and the issues of urgent health matters, that the sharing responsibility and the sharing readiness is increasing. However, especially in the market, in the food market and the competition. There the sharing is of limited readiness, basically. What have we done? We have written a scoping review. That means it is assess the availability of evidence, allowing organization to organize it into groups or highlight gaps, basically. So we were addressing what happens and what big data are available along the food value chain. What is the current situation there? We have addressed peer-reviewed databases, we have addressed the gray literature, and we have included papers from 2012 to 2022, English only and open access only. So you can imagine we have covered a lot, but there are gaps also in the literature we have looked at. So it is that's the perspective we are looking at. I will show you results over time and region, grouped according to segments of the food value chain and grouped according to type of big data analysts. Well, if you look first at the number of papers, well, that is what you would expect. Nobody was talking, or next to nobody was talking about big data in 2012. Data-driven decision, yes, but now we have a yearly publication of 600 publications which we use. It's not only the publication which are mentioning big data, but those we have selected because they are relevant for the food chain. Cumulatively, we have collected and boiled down our 30,000 and more publications into 1,600 publications or so, and you can see the increase over time. What you also can see is we have grouped it according, are these publications coming from high income, upper middle income countries, low income countries, or low middle income countries, or low income countries, and you can clearly see that there is a decline. Nearly 50% of all the publications are coming from high-income countries published in this region, and then you can see a steady decline, also already showing you what targets and what questions are addressed in these publications. If you go down along the value chain, and I basically have to now look, it's even too small for me, but you have the highest value not in the input, but in the production side. The upper part of the graph is basically the total numbers of publications, and there are over 1,000 publications of the 1,600s related to production. It's agriculture. It's what we have seen before. It's landscaping. It's satellite imaging of soil. It's satellite imaging of water resource. It's not only this. It goes down to drone technology to look at the fields, and it goes down to the machines which are harvesting and which are working on the ground. So all these data are summarized in this kind of production. Then you go through the packaging, then you go into distribution, then you have in the regulatory field, you have a small increase in big data issues because it's a traceability, it's food safety, and it's food quality, but it's basically food safety, and then public health. And in the other marketing areas, the number is decreasing again. Now, if you look at the lower part, it's structured the same way. But as you see in the y-axis, we are not any longer talking about thousands of publications. We are talking about tenths of publication. So food fortification mentioned in publication comes up to a maximum of 14 or 12 in the production and in the area of fertilizers and other areas. Then it goes down to one-digit numbers, and it decreases again a little bit in quality and regulatory issues, and then it drops again. And it again addresses more the markets. But what would you expect in these publications? We were happy if we found a publication where there were big data in the title or in the abstract, and somewhere in the text, the way of large-scale food fortification or biofortification was mentioned. There was a very, very limited number where there were a little bit more information than the fact that this term was mentioned. So basically, this is of very limited, so far there have been very limited publications. We have seen descriptive data, we have diagnostic data, predictive data, as we have seen with the satellite image. How can this be then extrapolated into the future? And prescriptive data, which crops presenting options on which crop plants can be planted, and so on. So there are different aspects of big data, how they will be describing the issue and how they can be used in further use. We have separated this as well according to the study, and what you can see here is, again, numbers are, now we have brought all sectors and all steps together, not any longer separated along the value chain. And again, if you look at the numbers which are related to mentions fortification or biofortification, then we have only 28 papers which are addressing the different issue. Most of them are descriptive data, very limited number of diagnostic, predictive or prescriptive data considering or mentioning food fortification. So you can see there is a very small number where all is related to. And the question is, how are we going to move forward with this data set? Well, the core challenges basically of big data generally, not only with regard to food fortification, they are siloed data. I'm a little bit comparing it. We have heard so much about data the last 2 days. Everybody was reporting about data and collecting them and making it available to the public. 10 years ago on scientific meetings, all scientists were coming with a little basket, personal basket with their own data in there. They were presenting their data and carrying them home with them. Now, at least, we are creating silos where everybody puts its data in. They have to be aligned because for inflammation, iron or vitamin A data have to be aligned to make it valuable for all. It doesn't make sense if you just pour your basket in there and leave it in there. You have to look what is in the basket. However, all these data are living in silos. If we look at mills and oil production sites, we have no access. We still have no access to what is going on in studies in the population. Basically, these silos are not connected yet. Basically, it's even worse. We have disconnected data. The data are not in any relationship being able to be connected. This has to be worked out. And it's a huge issue, is the dark data issue. Everybody who is collecting data collects data. 95% of the data they're collecting are never used. There's a huge question at the moment, how can this be conserved, how to use it later on? But if you conserve them somehow, storing them, it has huge costs to keep this storage upright. How are we looking at our data we create with our analytics? We create so many data, they could be used for other purposes, but there's no capacity to dig and put this data up on the iceberg, on the top of the iceberg. And the question is, we are addressing one question, we are looking at all the data, then we are extracting these data, and if you move 10 years ahead, you might have to readdress and have to look at different data. I think there needs to be a question and a structure how we can move forward in this. Challenges, yes, I have addressed the challenges. There is a big challenge is industry and different competing industry, government and industry needs to be ready to share the data they have. But there are challenges, data, we have talked about data protection and so on. I will give you a very short example, which we do with NI in Pakistan, and it's edible oil fortification. We have performed, it's a dashboard which gives you data, how many tests are performed, what is done, and these data are collected in mills. They are even collected remotely by driving a car where there is a lab in there. I like this picture very much. It shows the mobility of analytics nowadays if you have portable devices. And these data are feeding, and I'm not talking about the big data. I'm only talking about data-driven decision. And there are only one data point for each measurement set in. And you can see here a dashboard which shows you in reality in Pakistan, in the oil mills, how fortification is making progress. It gives you the number of analytes, it gives you the number of the volume of oil, and from there you can calculate, and the dashboard will calculate this, how many vulnerable peoples can be reached. So that's a first step to approach this. We need other data to feed in. That's a long but a very rewarding way to go, to make big data and to make only data-driven decision happens. And I think we need to go there step by step and see how we can progress. I'm not going into detail in synopsis. I would only like to show you that the global food market is about $8 trillion in value. These are the drivers of traceability. These are the drivers of big data. Global fortification market is about $70 billion. And if you go into food fortification, you might come at much lower values. And that is the challenge, that this low amount of investment or the low amount of money playing here is needs public-private partnerships to make it happen in this area. I would only like to remind you that using big data to food fortification, it's not only ending hunger, attributing to zero hunger, it attributes to resilience, it attributes to partnerships, responsible consumption, and decent work and economic growth. Thank you very much.
Thank you very much, Florian. Also wanted to mention that this paper was one of the series of papers that was commissioned by WHO and I in preparation for a meeting we held about a year ago on use of digital technologies in food fortification. And it's going to be published in an open access, a special issue of the New York Academy of Sciences journal, so it will be forthcoming soon. Our last speaker, but not least, is Dr. Dylan Walters, who is going to be talking about tools for empowering and decision-making and also advocacy in nutrition.
Thank you very much, Mandana. I like the late-in-life growth spurt that I get every time I speak here in Holland with the risers. Thank you. It's my pleasure to be on the panel speaking today to you about tools to facilitate the use of nutrition data for advocacy and programmatic decisions. I'm a health economist working with Nutrition International, and yep. Oh, it's coming up on screen. I think I know them off by heart, but I'll just introduce. In today's presentation, I'll give you a little bit of background on why we've done a lot of work over the last 5 years on developing tools for nutrition advocacy, what some of the data challenges and gaps that decision makers face that require us to develop. Oh, sorry, I'm getting distracted by the mouse on the screen. This doesn't look good. I'm just going to wait a minute.
Because your slides were in PDF.
Oh, is that it? I did this.
There we go.
Okay, my apologies for complicating it. I'll start again. Today we're going to speak to you about tools to facilitate the use of nutrition data for advocacy and programmatic decisions. I'm a health economist working with Nutrition International, and today I'll give you a little bit of background on gaps in data and challenges with tools for advocacy and decision-making, the role and opportunity of tools to support countries and partners that I see, and give an overview of the Nutrition International suite of analytical tools for advocacy that we've developed with some partners and are continuing to develop, as well as mention some other tools and approaches that I think are really useful to advance country level and global level advocacy and decision making. I know you've seen the World Health Assembly global targets by now, since they're almost finished. But I wanted to mention as a bit of a background as to why over the last decade or so have taken on this type of work in developing tools. When I first saw these WHA targets, realized that they were great for the nutrition community to have targets, but there were some gaps. We, or as a global community, but also country-level decision makers, didn't have data on the economic health and economic consequences of malnutrition at this level. We didn't have data on the cost it would take to reach these targets, what's the most cost-effective way to reach these targets, or the return on investment in the long run for taking action. So that provided some inspiration to take on work in economic analysis for nutrition and developing tools for nutrition advocacy. But there's still gaps and challenges, some gaps in the data that policymakers need. There's plenty of gaps in the data that policymakers need for advocacy specific to their unique context at the country level. And now often we hear of data gaps at the subnational level that are just as important as the global level data points needed to push agendas for budget and resource allocation. There's also very limited quality costing data available related to nutrition and health. And as well, there's high variation in costs and interventions and cost effectiveness between geographies to begin with. So we need to develop methodologies and tools that are easy enough for decision makers to use and that account for this. There are a lot of tools that have been developed over the last decade, but there's still some challenges with them. Some lack the basic input data available to use by policymakers and governments. That can act, some are too complex to answer focused policy questions. They often require multidisciplinary expert teams to guide users to use them still, and some lack the ability to be customized for user needs. And as Mandana earlier mentioned leveraging data for nutrition action framework, and I see there being plenty of opportunities in this framework for economic analysis tools to be useful, whether it's in the program planning phases or policy change, prioritization, advocacy, and funding, and decision making. And the three tools that I'll highlight in a moment are, through Nutrition International, use evidence-based modeling to estimate the health, human capital, and economic costs of the current levels of malnutrition, and attempt to do rapid value for money analysis for governments and donors as well. So the NI suite of analytical tools that can be used for nutrition advocacy includes three tools, two of which are available right now, and the third we're hoping to release in the very near future. Many years ago, we collaborated with, or I collaborated with Alive and Thrive on the cost of not breastfeeding studies, which led to an online tool. And in the recent years, NI and Alive and Thrive have collaborated to update that tool and maximize the impact of that tool as well. Nutrition International, through the Maternal Newborn Health and Nutrition Unit of Global Technical Services, developed the MMS cost benefit tool that helps countries that are struggling with the decision on whether to transition to MMS from IFA as well. And now we are working on and have developed the cost of inaction tool, which builds on what the cost of not breastfeeding tool, but focuses on the other three global nutrition targets on stunting, anemia, and low birth weight. And I'll show you a bit more about that in a few moments. But first, since we've had a few years of experience from these other two analytical economic tools for advocacy, I thought I'd share a bit of what their use and impact have been like. In only 4 years of the cost of not breastfeeding tool being online and available, with data available on the cost of not breastfeeding for over 120 countries, we've seen a significant amount of policy influence in certain countries in Indonesia, Timor-Leste, Malaysia, West Africa, Nigeria, used in regional forums like ASEAN and IPU. And even today, it's being used for reasons that we hadn't predicted, like advocacy for human milk banks in Vietnam. It's gained a fair amount of media attention at its launch, as well as academic attention, and continues to be used in advocacy events for World Breastfeeding Week and cited in various global guidelines. The MMS cost benefit tool developed by Nutrition International was based on rigorous academic research on the cost effectiveness of multiple micronutrient supplements. And that underlying economic model was applied to this online tool, and with the ability to replicate that kind of analysis on whether MMS is better value for money than IFAS for 33 countries. And since its release in 29, this tool has been used in some really fascinating ways. At the country level, in some examples in Nigeria, Mali, South Africa, Ethiopia, Pakistan, and Mexico, but also at the global level. Like, it was instrumental in producing a technical report for the WHO review of MMS during pregnancy, which contributed to the WHO updated guidelines on antenatal care that included MMS in 2020. And even today, it's continued to be used as an instrumental part of implementation research and through some of our grants and programs in Pakistan and Nigeria and others in the future, I'm sure. So with the experience of these two tools in our background, we've tried to expand, from a single intervention and a single, area of interest like breastfeeding to the other areas where there remain gaps on the economics of malnutrition, being stunting, low birth weight, and anemia in women, but also we've included anemia in children in this new cost of inaction tool. So this tool, in a very user-friendly way, simply tries to answer the question, what is the cost of malnutrition, stunting, anemia, and low birth weight in every country in the world, or regions, or globally? And we believe that's powerful data for not only advocacy groups, but policymakers and others who are interested, that they can use in their advocacy or budget briefs or program planning to advance their initiatives to either change policies or increase investments in nutrition. So this new online tool will be available for over 100 countries and have data available on those costs, not requiring any data entry, for over 100 countries in both French and English, and can be looked at on an issue basis or on an aggregate basis for your geography of interest. It also includes a feature on what if action taken now, allows the users to see what the economic gains and the health gains could be of if action is taken now to reduce a prevalence from X to Y. And we think that is also a quick way of doing an economic analysis for policymakers, and can be very powerful. The data that comes out of this tool is fairly vast and instantaneous, and provides information on the number of cases, as well as mortality, some human capital outcomes, as well as mainly the economic costs of malnutrition under these pillars for all of the countries in the tool. These data points, as we've said, we think can be really powerful for building political will and for advocacy. Just to give you a sense of a couple data points, but there are literally hundreds of data points coming out of this tool that can be used in different contexts. This tool can generate data points such as $4 trillion is in productivity could be lost globally due to stunting by 2030. Or $990 million could be saved per day in preventing stunting and anemia in Asia alone. Or $1.6 billion could be saved by reaching the World Health Assembly target for low birth weight. And 16 million IQ points lost per year are lost per year due to low birth weight in SADC countries. So these are just some examples of data points that, if used by the right people at the right time, could be very powerful for advocacy and decision making. Supporting this tool, we'll have the online tool available in the near future, as well as knowledge briefs, regional knowledge briefs, country-level printouts, and hopefully slide decks and other methodological documentation available. Of course, any of these tools that we speak about on the panel, but that are available out there, require some capacity building with national and regional users and decision makers, and we hope to be able to provide technical assistance and support to users, and hopefully follow up with in-depth analysis if it's needed. You can Google the two existing tools, Alive and Thrive Cost of Not Breastfeeding tool, as well as the MMS Cost Benefit tool, and very soon the Cost of Inaction tool will be available as well. And lastly, I want to acknowledge there's some other great tools out there that are useful for governments and their partners to use, such as the new MAPS tool that I think we've heard about at this conference will be very powerful and provides or answers a different set of questions, as well as some that are specific to fortification. And also on breastfeeding, the new Mother's Milk tool and green feeding climate action tools, I think are similar to this tool, but answer different policy questions. Just to conclude, I think these economic modeling tools for advocacy have proven very successful for reasons at the local and global level and in influencing policy and informing investments. And they can help increase access to data for countries unlikely to have detailed studies and potentially even motivate further in-depth analysis. But I'd like to hear from you if you have any questions or ideas on how we can maximize the impact of these tools for advocacy and what are some suggested applications of the cost of inaction tools. Thank you very much, Mandana and the panel, and thank you all. Bye.
Thank you very much. So we have a few minutes for question and answers from the floor. Please feel free to come to the mic. And we also have questions posted online that I will go to in a few. Please.
Hi, my name is Carrie Wozni. I'm at SIF. I had a question for, I'm forgetting your name now, Dr. Noor. On the modeling. What was the difference from some of the groups of the clusters, and how could they be used to target interventions or programs? Because I know there were some female rural households that were the least vulnerable and some female rural households that were the most vulnerable. Thank you.
Thank you for your question. So some of the variables that define those different levels of vulnerability was, for instance, the women's agency in decision-making, or having the power dynamic in the household. For instance, whether they can decide where to go and when and where to go to use health services, whether they were using family plannings or not, and as well as having how many children they have, what are the number of children, what is the household's population. These were some of the factors that define those different levels of vulnerability.
Hi, I have a question for Abe. You were mentioning how the data is updated yearly, and I'm guessing that that's from your Earth observation data. But given that you're predicting out the future, I'm curious what you do about older survey data that you're using as your base, and especially with what we've been learning this week around how a lot of the micronutrient indicators have really fallen after COVID, how you can then use your data to show that change.
Excuse me, thanks for the question. So we have seen a need to adapt models to a significant shock like the COVID pandemic. Part of that has been in refreshing survey data that we have access to and making sure that we have new inputs to retrain the model. But at the same time, we are focused on predicting outcomes that are associated with measurable, observable changes in this imagery. And so, for example, changes in wealth, changes in access, changes in population,
we're seeing continued reliability in the model in order to, even in this midst of significant structural change in many of these communities, predict out change as of 2022, 2023. When we start looking at forecasting models over the next 4 or 5 years, what we're finding is that in many cases, 2020 and 2021 need to be treated as outliers within the model. And so because we have the benefit of over 20 years of satellite imagery, and associated with that 20 years of historical trajectory of many of these indicators, we have enough history there to be able to still, with short and medium term forecasting results, reliably show how these communities are likely to structurally adjust.
All right, thank you. My name is Balaji Adewi from Bells University. My question goes to Nutrition International and great work that you're doing. And I want to ask, what's the plan to generate localized research as regards MMS? That's number one. And that's important because I think the earlier speaker spoke about the fact that we could use these models to generate prescriptive, analytics. And it's also important that as we're planning to scale up, is there a plan to begin to engage maybe the scientific community in those countries where we operate to generate, forward-thinking research? That's number one. Number two, why this conversation is important to happen is because during the last WHO recommendation that just came out, there were various recommendations that has to do with MMS, LNS, and their outcomes. So does Nutrition International has plans to engage localized research in these countries such that going forward as we generate these models, right, this research will begin to inform programs and policies? Is there a plan for that? Thank you.
Do you want me to comment on that, Dylan?
I can comment on the costing, exercises, but if you want to comment more generally on MMS.
I can comment more generally on MMS. Yeah. I think that's a great question because there's, again, and I started talking about this a bit, there is a use for modeling and, these broader kind of applications, analytical approaches. But that also needs to be connected to real-world data and research that makes it applicable to the context. And there needs to be a connection between the two of them. Even, with Davide before the meeting, I was thinking of asking her this question because, the models can benefit from the data that comes from this really contextual research. And the other way around, I think sometimes also it helps us develop and nuance the research agenda for the contextual research. So I agree with you. I think what we've been doing related to the multiple macronutrient supplements has been that following the recommendation of WHO that says, you should introduce these new interventions in the context of rigorous research. So rigorous implementation research, which means look at the context and really help the decision only when it works within the context. So for example, in Pakistan, we've been working with the government and partners to do implementation research on how you would even shift from iron folate supplementation to MMS, what it would take, the kinds of training that the system would need, how would the health workers receive it, how would the mothers receive it. In Nigeria, we are looking at human-centered design on how to communicate about these new interventions so that there is more uptake from the recipients. So definitely plans for that and a lot of recognition for the importance of that contextual adaptation. Probably we have to, as a community, talk more about the importance of this implementation research. And again, the focus that we have on big data and some of this novel modeling and analytics doesn't take away from the importance of implementation research. And we see these two as complementary. Dylan, please feel free to add, and also others on the
Thank you. Yeah, just briefly to build on Amanda, with respect to costing data for MMS, I think the tool just provides a general calculator essentially for countries to adapt it and customize it for their context. It still requires local costing data to be collected as much as possible to make the tool's analysis as high quality as possible. When we developed that tool, we noticed observed that there is a big gap on how much the transition from IFA to MMS would cost. And so we've taken on a few implementation research projects, as Mandana mentioned, in Nigeria and Pakistan to try to answer those questions. But there's still also data gaps on, the cost of local production of supplements. Can we do it in different countries in Asia and Africa at a different cost than the UNICEF supply cost or catalog, for example? So there's a need for both tools at a global level, but it's only as good as the inputs. Thanks.
Does anybody else? Do you want to make a comment also on that one?
On the modeling aspect
Yeah,
of
and
it?
how that relates to implementation research.
Yeah, I think the relationship between when we develop a model as well as using the actual data and field research, they are iterative in my opinion. So you can use data to inform our model to be able to validate and calibrate our model and make sure that we are doing right in terms of parameter estimations and assumptions that we are making. But also we can use models to be able to do scenario-based simulations, hypothesis testing to just, for instance, see potential effects of an interventions on a set of outcomes that we are interested in. That maybe there have been some trials developed on it, some field research developed on it, but we don't have information beyond that. So what are the potential effects that we can see by developing a model to conceptualize the real world scenarios and the real world system that we are focusing on. So I think they're all iterative and interconnected with each other. So
thank you very much. So I'm going to take one question from online and then yours would be last. There is a comment on how important it is to focus on traceability, and especially the fact that a lot of processed foods in Africa, for example, come from other countries and there's no traceability of where they're coming from food safety and also from nutrient intake, nutrient content perspective. So I was wondering, Florian, if you could comment on big data and whether there are specific applications of big data to improve the traceability.
Yes, well, I think the food traceability is a big chance because there's a creation of a lot of data. I'm looking more in the high income countries at this point. There's a very well established chain on these big data with traceability, and there is also big data involved in it in this way. I think the challenge will be how to boil it, not boil it down, but to also get it into low and middle income countries to get all this value chain, because, well, it's a difference whether you have big fields and farms which are having hundreds of thousands of hectares which are working on, or whether you have a small field where you have to do it. I think this is the biggest challenge. It's the economy of scale in the way of, if I have a big company, a huge international one, then it's not an issue. They are using the data to have an additional business in this way. But the small scale, it's not an additional business for them to use the big data. Nowadays, farmers are giving the data to the companies who are selling them the devices, then they get the data back to the companies, and companies are selling the data back to the farmer to use so. So I think that's a completely different story.
And do you think then in the lower and middle income countries there's a role for the public sector to make investments in this, well, since there are no big companies?
I think so. I mean, that the discussion, I have somebody here who sit work for a non-profit. Yeah, I mean, I'm for profit and non-for-profit in a way. I would not be able to do what we do in Pakistan on the for-profit level, but it is a sustainable question. So we have to start with, and I think these collective approaches we are having is also contributing to this on the long run. So I think these partnerships are the nucleus, and the nucleus has to crystallize into something big. And I think we are moving along this road very nicely.
Thank you. Thanks for that comment. And last question, please.
Good afternoon. My question is on the tool for inaction, because I'm interested in that. Does it include the prediction model for a low birth weight? Can it?
No, that's, that isn't, I guess, the purpose of the tool. No. Mm-hmm. It focuses on estimating the health and human capital, economic cost of low birth weight at current levels.
Okay. When will it be out?
In the next few months, but stay tuned.
Okay. Thank you very much.
Thank you.
Okay, well, thank you very much, the panelists, all the audience, for staying here till past 5 p.m. Really appreciate your resilience, and hopefully you benefited from being here, and looking forward to working in this field together with the community.